plans are worthless, but planning is everything. In this type of scenario, you cannot make it up on the fly. You've got to have your plans in place well ahead of time. The most important pearl of wisdom I can share is that you've got to put your head together with your team well in advance of this event actually occurring.
Enter the world of military trauma surgery with Frontline Surgery, where we bring you expert insights and real-world scenarios to help surgeons stay ready.
Brought to you by the AAST Military Committee. Join us as we engage in conversations with field experts, examine critical battlefield scenarios, and uncover the strategies that keep surgeons ready for anything.
Stay prepared and stay sharp with Frontline Surgery, where every episode provides key insights into mastering military trauma care. Welcome to Frontline Surgery, Mastering Military Trauma Care. Again, I'm Joshua Dilday, one of the co-moderators, and I'm joined by my illustrious co-moderator, Rachel Russo. Rachel, thanks for joining us today. This is a great topic.
Yeah, thanks, Josh. Thanks for the introduction. It certainly is. This is one of my favorites, and we're going to be joined with an excellent guest today.
Absolutely. And to remind everyone, this series is built to prepare early career military surgeons for the realities and uncomfortable realities of deployed trauma care. And today's episode focuses on just that, one of the most high-stakes events that you may face downrange, which is a mass casualty event, or MASCAL, as it's colloquially termed. Now, these not only test your clinical skills, but also your leadership, your communication, your triage judgment, and your ability to operate under the extreme resource constraints in the battlefield environment. And we're joined by an expert in this, Dr. Jeremy Cannon. He's a repeat guest and a military trauma surgeon and leader in combat casualty care who has directed surgical teams through real-world MASCAL events and understands firsthand what it takes to manage this surge in a combat environment. Dr. Cannon, thank you so much for joining us today. And again, as a repeat guest on the podcast.
Josh and Rachel, it's such an honor to be with you. I really enjoyed our first recording on damage control surgery, and it's an honor to be back with you. I agree. This is a vitally important topic. And as I did in my first episode, I just want to foot stomp the value of the book, Frontline Surgery. For those of you that are more visual learners than audio learners, I would commend this resources in the Frontline Surgery book to you on this topic. Specifically, I'll name chapter and verse here, chapter 2, chapter 40, and chapter 43. Will equip you well. I also just want to underscore the emotions that this topic can generate. There are strongly held beliefs about how best to manage a MASCAL. It's also a very intense experience when you're in a MASCAL and then afterwards. And I just want to share a little blurb from the preface by my friend and colleague, Al Beakley. Al shares with us in the preface to the book, of the first 5 casualties I treated in Iraq in 2004, after joining my forward surgical team, 2 died and 1 lost his leg. 4 of these casualties arrived at the same time. Their wounds were appalling. 1 casualty had been blown out of the Humvee turret, ruptured every solid organ in his body, and broke both his legs. Another had a head injury, impending airway loss, flailed chest, ruptured thoracic aortic arch, ruptured spleen, and open femur and tib-fib fractures. We had a total of only 20 units of blood. For a 2-surgeon forward surgical team, it was a humbling and overwhelming experience. So brace yourselves. This is where the rubber really meets the road. Josh, in your terminology framework, this combines both in-the-tent skills, clinical acumen and expertise, and out-of-the-tent skills, leadership, communication, and synthesizing a system of care.
Absolutely.
That's an excellent introduction to our topic. And I'm glad that you brought up a scenario that happened in real life, because we wanted to have this podcast today be centered around a scenario that didn't actually happen, but one that really could. So without further ado, let's imagine that you're talking to a young surgeon who's about to deploy on their first component of being in a role 2 on a forward surgical element, that their team consists of 1 anesthesia provider and 2 critical care nurses, and they are now approaching midnight when they get a radio call. Similar to what you described, there's a complex attack on a patrol base, and they know that there are multiple casualties inbound. So when the first vehicle arrives, they recognize that this isn't like 2 or 3 casualties. They're now faced with 12. 3 are unconscious, 2 have extremity amputations, and some are walking around. And they noticed that one has a penetrating chest injury and is rapidly decompensating. With a limited blood supply and an uncertain evacuation time, and the thought that more casualties may be coming in, what should be that surgeon's first move?
Well, that's a really excellent way to frame this challenge. I'd like to first quote Dwight D. Eisenhower, who's famous for saying that plans are worthless, but planning is everything. So, in this type of scenario, you really just cannot make it up on the fly. You've got to have your plans in place well ahead of time. So, I would say the most important pearl of wisdom I can share is that you've got to put your head together with your team well in advance of this event actually occurring.
I think that's a really great advice for starting. Whenever I imagine the concept of triage and preparing, there's a lot of different thoughts on this. What do you do with those walking wounded? Because you know you have limited surgical capabilities, and there's at least one of those patients who's going to need your surgical care. But as soon as you put hands on them, you lose situational awareness. So, can you treat the walking wounded? Do you leave them alone? Do you use them as extra hands?
I'd like to step back a little bit onto what a famous Harvard Business School article calls the balcony. You got to have sort of the 30,000-foot view first, and then we can get into the weeds of the specifics. So you have some vitally important roles that individuals need to play. I'd say the most essential role is the triage officer. So this is something that I didn't fully appreciate when I was on the verge of deploying, but came to appreciate later in my active duty military career. Textbooks from the, say, late 90s, early 2000s would say, well, it's the dental officer can do this. And I, I'm not disparaging dental officers. They take great care of my teeth. Some of them become oral surgeons. And in fact, my son is an aspiring dentist. Are they prepared really to make critical life and death decisions on that pointy forward edge of battle? As I think of it, in the trauma bay when the casualties are rolling in, I think not, unless they're a really exceptional dental officer. So you need your most experienced clinician willing and able to make accurate judgments on a moment's notice. Often that will be a senior surgeon. So some may say, well, shouldn't your surgeon be in reserve to go to the operating room? It really depends on how many folks you have on your team. This sort of small team, I would say it would be between your anesthesiologist and the surgeon, and probably the surgeon for starters. But you have to have a shared mental model of how are we going to manage this influx of casualties, and that triage officer really is the, I would say, the most critical position player in the mix. Others that are really critical, your pad is critical. You got to keep track of the patients as they move through the facility. You got to keep track of their injuries and keep track of who's in whatever imaging location you might have, who's in the operating room, who went to the delayed area, and what have you. So triage officer and then pad. You're going to need to be in frequent, if not constant, communication with your lab about blood bank resources. In fact, you should know that off the top of your head from morning report. If you pay attention to nothing else in morning report, pay attention to how many units of blood you have, and of course, how many beds you've got available. So triage officer, pad, lab, and then you need runners and communicators. In the midst of this chaotic environment, it's going to be quite difficult to relay messages. There's going to be the fog and friction of war. So you need communicators that are designated and know their role in terms of passing messages and keeping the flow going. None of this happens as a pickup game, or it doesn't happen well. So it's vitally important to drill and exercise this, as mundane or as unappealing as that may be. It will save lives. And it will also give the team confidence that they can save as many as possible with the resources that they have if you drill this on a regular basis. So create your MASCAL plan, or update it, understand it, internalize it. It can't just be a sheet of paper that's locked away. That's where Eisenhower's quote comes in. That paper becomes really worthless in the heat of the moment. It's the internal knowledge that you have and that your team has, because you've done this before, and you know that you'll make good, sound decisions early on and get folks to where they need to be.
Thank you. So I think that gives us a pretty good idea of how to address it whenever we've got a team, maybe also at a roll 3. Do you want to talk about how you adapt those principles to this roll two really small team scenario when you only have a few folks?
You're in a really resource constrained environment as you all set up the scenario here. So this is going to be tough. This is going to be similar to the little blurb I read from Dr. Beakley, where you're basic. This is 12 patients is essentially a tsunami of patients swamping your forward surgical team. In terms of triage and immediate decision making, you need to have a system in mind that you're familiar with and that you're comfortable with. And I'm going to use some word salad here, and I unfortunately, you know, uh, don't have all the acronyms down pat, but there's START, there's SALT. The one I was recently introduced to that I really love is the 10-second triage tool. That's a name I can remember. It is very intuitive, doesn't require you to remember an acronym, and it really is built for clinicians that you are faced with this sort of challenging situation. So it starts by identifying whether the patient is walking, yes or no. Very easy to determine if they're walking. If I'm confronted with, say, an ambus of patients, I just say, if you can stand up, come to the front of the bus. If you can get off the bus, follow me off the bus. And then that way, everybody who's not walking is left on the bus. So the walking, that's priority 3. That is essentially your delayed group in the 10-second triage tool framework. That's priority 3. What you really want is to sort the immediates, which are priority 1, and immediate surgical priority 1 plus. So walking, yes, no. Those that cannot walk, you assess for severe bleeding. And if there is severe bleeding, you apply a tourniquet, you apply pressure, packing, all the ACS stop the bleed, TCCC interventions, and then those patients become priority 1. So, as you're going through this, you have to have a designated space for these patients. The Frontline Surgery book talks about a triage triangle so that, priority 1 sort of ends up right, front and center. Priority 2 and 3 are off to the sides. So you should have a designated space for each of these different categories. So we talked about priority 3 being those that are walking, priority 1, those with bleeding. If you don't see severe bleeding, then you get down to whether they're talking and whether they're breathing. And this is where it gets a little tough. So are they talking? Yes. If they're talking, then you look for any wounds. So do they have a penetrating injury? If they have a penetrating injury, then they're priority 1. They're in that, possible may need surgical intervention. If they're talking but they don't have a penetrating injury, then they go into that intermediate category. And then talking, they're not talking. Now you're down to are they breathing or not? Breathing, yes, no. That's where you have to make a tough call. If they're breathing but they're not walking, but they don't have severe bleeding, but they're not talking, then they're also priority 1. So your priority 1s end up being those with basically torso injuries, severe bleeding. If they're not breathing, then that really is, at a resource constrained setting, that's going to be an expectant patient. If you're flush with resources, then, CPR, some sort of resuscitation would be indicated. So that's the 10-second triage tool. I really like it. It's intuitive and it helps you sort out a large number of patients.
Dr. Cannon, you mentioned knowing your resources. You talked about there's only a couple things to know your bed capacity and your medical logistics, and you specifically mentioned blood. The majority of people listening to this podcast are going to be surgeons, and surgeons want to save lives with doing surgery. How do you determine in that constrained environment which patient goes to surgery first, which patients don't go to surgery, and which patients can't get surgery?
Yeah, that's going to be a case by case kind of decision. That's where that surgical judgment really comes into play, and you've got to consider the whole situation. How many patients really have survivable injuries, and who doesn't have a survivable injury, or who's so badly injured this is not salvageable. Could you find yourself doing a resuscitative thoracotomy in this situation? Yes. Is that likely to yield good outcomes for not only that patient, but the others that might be sort of not quite peri or rest, but salvageable? It's not going to be great. So if you're swamped with patients and you have such very limited resources like you described in the scenario, you probably wouldn't be doing resuscitative thoracotomies for someone who's, again, going back to that 10-second triage rule, not breathing, and then of course no pulse. So Who's going to get surgery first? That is a tough call. I would say a patient with junctional or possibly torso injury that needs immediate surgery. They in my mind would have priority, but you have to assess the whole situation. Again, you need that triage officer on the balcony also to make the call. Okay, we've sorted all these patients now. Which of these priority 1 patients is going to go to the OR first? And that's the senior surgeon that's got to make that decision.
And then the surgeries you're talking about, I'm assuming that this is not where we're doing a complex vascular repair or multi-layer, 2-layer anastomotic closure with the divergent loop ileostomy. This is what I'm assuming what you've talked about in your previous episode on damage control surgery. That's the role in this, right? Is that what we're talking about when we're talking about the surgeries in a MASCAL and VIT?
Yeah, that's absolutely right, Josh. You've got to be high speed, low drag, and remember that there are other patients that might not be able to evacuate until you perform a critical intervention. So you're now thinking in a role 2. Okay, I'm going to do whatever I can to stop contamination and exsanguinating hemorrhage, and I'm going to give this patient a chance at survival, and then I've got to get them on to the next phase of care. And now contested environment, congested battle space, difficult logistics, lack of air superiority, much less air supremacy, will perhaps change your equation. If you're in a prolonged field care kind of setting, and you know that you're going to be caring for these patients for a while, but that may adjust things a little bit. But I would say the first wave, you're thinking damage control all the way, whether they're going to leave your facility or not. You got to get through very quickly. Then I'd say just a word about communication. That triage officer, if they're the surgeon and the sole surgeon, they may have had to hand that off to someone else while you're then going to the operating room. You need to quickly circle back to that triage officer, have them come into the OR to tell you what the situation is out in the resuscitation area, and if there are other casualties potentially on the way. So maintaining situational awareness, communication, going back to blood, thinking about a walking blood bank. You've only got limited supplies on hand. You need to gen that up pretty quickly if you've got a bunch of priority 1 patients. So yeah, communication. Then, I think we'll get to the sort of the aftermath, but, communication and debriefing is also vitally important.
As we think about the ways in which the surgeon is a leader in these environments, I imagine you can really set up your team for success, or you can end up walking them into failure. Can you talk about some common pitfalls in that leadership approach that our young surgeons can try to avoid?
So as a surgical leader, you really need to prepare and plan with your team so that you have a shared mental model. If you are uncertain, anxious, uptight, that will be clearly reflected in your demeanor, and that will transmit uncertainty to your team. So having your own mental game together and then working with your team to get prepared, I think is really essential. In the heat of the moment, it's important to be calm, cool, collected, have confidence in your own abilities and your team's abilities. And that really only comes through planning and preparation.
So, Dr. Cannon, a lot of the recent models of civilian military partnerships focus on clinical skill sustainment, and we're starting to switch now to a systems level of readiness. Part of this readiness that you've talked about is building your team. How do we train in a civilian integrated system for a deployed MASCAL environment? Caveat to the question is, how do we prepare in that MASCAL environment in the future battlefield, which may be very different than the scenarios at which Frontline Surgery, the textbook, incorporated in their clinical expertise?
Josh, there's a lot to unpack there. So, first of all, let's go, beyond the role 2. Many facilities will be inundated with lots of patients all at once, including potentially civilian hospitals here in the continental United States. So it's important for our civilian colleagues to be thinking about their own MASCAL plans in their hospitals, to exercise them with care, diligence, and attention to detail, not just being satisfied with tabletops, but actually going through the MASCAL exercise deliberately and take opportunities as they come up. We had a joint military civilian exercise here in Philadelphia just a couple of years ago. We landed a Black Hawk on our civilian helipad, and they had basically the scenario was a hypersonic dirty bomb warhead landed in Philadelphia. We had a bunch of mocked up casualties, and we took that very seriously. We had our civilian clinical team, we had military folks all working together, and there were a lot of after action bullets that we're continuing to work through. But those sort of opportunities are invaluable, especially as we're thinking about a LISCO kind of setting. I would also say, there's a lot of concern about the expectant category. You're going to be faced with decisions, tough decisions about where's that threshold where, if I had all the resources available to me and a limited number of patients and more clinicians than patients, then, I could do everything for every patient. It's not always going to be the case, and you'll have to be steeled for making those tough decisions in some instances, having a patient become expectant. So think about that ahead of time, prep your team for that. There's a very practical guideline in the Frontline Surgery book that talks about, where is your ward going to be? Because you're going to have teams that are going to want to come in and pay their respects. So don't put it in the chapel. Don't put it in the dining facility. Have a place off to the side that's climate controlled, where the deceased can be laid, and the teams can come by and pay their respects. So there's just so much to dive into and unpack. I would really commend the Frontline Surgery chapters to your audience, and then I would also direct them to the newly updated American College of Surgeons resources on this topic. The disaster management and emergency preparedness course has undergone a complete refresh, and the course is now available online. So it's much more widely accessible, and I think more in line with adult learning, and will I think be a meaningful first start for a lot of folks that are anxious about this topic and don't know quite where to turn.
Thank you so much, Dr. Cannon. Those are a lot of really important points about leading under pressure during these mass casualty events. And it really hits home that the preparation starts ahead of time with that shared mental model and approach of the team to triage. As the surgeon, your tone is going to set the pace. So if you lose calm, so does the rest of the team. And then things really start to go off the rails. As we go into these situations where there's a chaotic environment with multiple casualties, the ability to prioritize, delegate, and then communicate clearly is going to have as much importance on the outcome as any technical skill. So we really have to drive home the point that we should be practicing those leadership skills as much as we are practicing our cutting and sewing.
Absolutely. I couldn't agree more. And thank you so much, Dr. Cannon, for joining us. Repeat guest. Anytime we can get you on Frontline Surgery is just such an honor. So don't be surprised if we ask for you time after time and again. You're a wealth of knowledge and expertise and a favorite of the moderators here. Well, as we learned, MASCAL is going to test everything we know about trauma surgery. But you mentioned, and Dr. Russo mentioned, preparation, rehearsal, and then discipline leadership make the difference. So train hard, whether that's in our current military environment, MILSIP partnerships, with lessons learned from counterinsurgency operations and newly extrapolatable research coming out of the LISCO environment is going to change the way we do this and make it even more difficult. So as we say on Frontline Surgery, we're going to say again, until next time, stay sharp, stay ready. Thank you.
Thank you for tuning into this episode of Frontline Surgery. We hope today's discussion has provided valuable insights into military trauma care.
Be sure to join us next time for more expert perspectives and battlefield-ready knowledge. Until then, stay ready.